Welcome to my talk. I'm Teresa Warmke. I'm here to talk about how to make your own decisions about healthcare products. I'm all for obsoleting the FDA, but it would probably take a while. And one of the most important factors in that is to help people really think about healthcare products and not just trust that if it's something their doctor recommends because it's approved, that means it's good. And so my talk is really to explain some of the ways that you can think critically about data you see and advertisements you see about healthcare products. I'm also with Free Aid, just like Stephanie, and thanks for your kind words, Stephanie. It is a pleasure to work with Free Aid. We are an organization that has that networks with a lot of medically skilled liberty lovers, and we've got about 50 members of our Facebook group now, and I'm delighted. Chip is one of them here, and Stephanie and several others. And we're here providing first aid services as well for the festival. So far, we haven't had anything too serious, as I know, and so that's great. And I am also going to be doing CPR workshops at 1 o'clock today and then 1 o'clock on tomorrow as well. And it's also very refreshing to see how many people were interested in mutual aid for Stephanie's talk earlier. And CPR is a good example of mutual aid, people helping each other without having to, being empowered to help each other without waiting for government providers. So, all right, so some of the things to look for in a health study, to summarize, is the study design appropriate for the question being asked? Is the study well conducted? Were subjects informed of risks beforehand? It's very important ethically. How strong are the results? How generalizable are the study results beyond the study population? And what percentage of patients benefit from the treatment? So these are all important questions to ask. And just to pull, how many people here have either had a procedure or a prescription drug or a loved one that has had a procedure or a prescription drug? How many people here have really looked into some data about their products? Good, excellent. I always do. I know too much. I work in the medical device industry, and I just know too much about what FDA does and doesn't ask, and how data can be interpreted differently in different circumstances. So I'm here to help provide more information about how to ask good questions about the products that you or your loved ones receive. So there's two primary problems with healthcare product data. One is confounding. So what that means, if choosing the treatment or exposure is related to other causes of the outcome, you might see a spurious relationship. So I'll talk a little bit more about this in upcoming slides. And bias is that if the assessment of the exposure and outcome are related in some way, you might also see a spurious relationship. So I'm going to talk about each of these in turn. So confounding, an example of a confounding error is you're looking at the relationship between coffee consumption and cardiovascular disease. If people who consume coffee are more likely to have unhealthy lifestyles, maybe they smoke, maybe they don't exercise very much, then you might end up not making the right conclusion unless you control for that, those confounding variables. And then another example is it can work the other way as well. If you're looking to see if taking a multivitamin supplement will help some kinds of cancers, and people who take vitamins also have healthier lifestyles, you might see a confounding relationship that isn't causal. You might make a conclusion erroneously that taking vitamin supplements helps prevent cancer, but it might be related to all these other variables that are going on in that study. The other type of problem is bias, and that occurs when there is mismeasurement of some kind, and when there is poor measurement in both the exposed and unexposed populations, then that can dilute a true effect so that you wouldn't see an effect that really was there in some cases. And in other cases, when there is different measurement of one outcome versus another, or to the exposed population and the unexposed population, then it can make it seem like there is an association when it's not really there. An example of different types of biases, recall bias. So this is kind of well understood. People with the outcome may be more likely to over-remember. Those without the outcome are more likely to forget. So it's, you know, the example we're giving here is cell phone use. If someone develops a brain tumor and is asked, you know, about cell phone use, they might remember, oh yeah, I used cell phone. But if they don't develop a brain tumor, they're not likely to remember that at all. Ascertainment bias occurs when assessment of the outcome is different between the exposed and unexposed. So, for example, hormonal contraception and embolism. Women who use control pills may be more likely to be screened for embolisms because of more frequent contact with doctors and concerns about the association. And the more you screen for it, the more you're likely to find it. So that's an ascertainment bias. And then another type of bias that happens a lot in healthcare product studies is loss to follow-up. So if you're doing a study over a period of time, the patients who, you know, usually there are predefined intervals at which they're going to be measured for different outcomes. And if what happens is that some of the patients drop out, they don't want to continue the study, or something else happens, and that's not always random the way that happens, you know. So if a drug causes serious side effects, more of those taking the drug may drop out than those who don't take the drug, and so then the results might look better than they are. And yeah, so that may look like there are lower risk of adverse events in that group that dropped out. So here are some ways to control for these problems. One of the best ways is randomized controlled trials. Not all healthcare products go through randomized controlled trials, but it really helps eliminate some of those issues. Randomization from a treatment group and a control group really helps control the confounding variables if they're really randomly assigned across a population. You know, to ensure that the comparison groups are similar on all characteristics other than the measurement, other than the thing you're measuring. So that's important with randomization. And some randomization schemes are better than others. So, you know, if you look at a study, be sure to think about that. And then the control group, making sure there is a control group, has to be adequate. And for drug and device trials, if there is no known effective treatment, new treatments are tested versus placebo. But if there are other treatments for the condition right now, like for instance blood pressure or something like that, there are currently effective treatments for that. You have to treat it. You have to test it versus the standard of care, and it's tricky because sometimes the standard of care can vary by location and in different countries, and you name it. Blinding is another method to control for some of these issues. It's used to prevent bias. And if patients know they received an active drug, they may be more likely to report improvement. It's kind of known as the placebo effect. You know, they're more likely to report improvement, and they're also more likely to report side effects if they think they have the active treatment. But if patients know they received the placebo, they may drop out of the study, and they may decide to take the drug on their own, and it can cause issues. And if a researcher or evaluator knows that the patient received the active drug, they may be more inclined to see improvement. And but one of the issues is you can't always blind subjects or researchers. You know, like if it's a really invasive procedure, some kind of surgical procedure or something, it's really not ethical to do a sham and not really do it. You know, so it can be really difficult, but blinded studies are generally more free from bias than others. Some of the limitations of randomized controlled trials, the study population is usually very specific, so you're trying to isolate the variable in question, and so generally they get, you know, pharmaceutical companies and medical device companies try, when they do randomized controlled trials, to have a very specific population that might not always be applicable to the broad population. You know, this happened with Vioxx, for example. They studied a very narrow population, and then it got used for a lot of different things that weren't always well studied. randomized controlled trials should only be conducted when there is a state of equipoise. There's a legitimate question as to whether the treatment is beneficial or not. There has to be equipoise between the treatment group and the control group to make it ethical, even. You can't conduct a trial where a drug with known effectiveness is withheld. Like when I was talking about blood pressure earlier, it wouldn't be ethical to tell people, you have to stop taking all your meds so that we can study this new one. That's not appropriate either, if it really is standard of care, although some blood pressure medicines are better than others. Let me put that caveat out there. And you can't conduct a trial where exposure is likely to be harmful to a subject. So you can't assign someone to start smoking cigarettes to study the effect of it. Another example of this is like the defibrillator that we have at FreeAid. I worked at the company that made it. When we designed it, we made the waveform extremely efficient so that it could be in a small device, portable like that one. And it was not according to the standard for defibrillator waveforms. And we were able to do a clinical trial at that time because back then, when people were receiving implantable defibrillators, it was standard of care to put them into ventricular fibrillation to test the implanted device. But the implanted devices are so good right now that, that they no longer need to do that. So no one ever gets put into VF anymore, which is a good thing. VF is not a good thing to be in, even when you have a defibrillator right there that is going to bring them out of it. But because of this, it's not possible to innovate new defibrillation waveforms anymore. Because in the case of an automated external defibrillator for cardiac arrest doesn't occur often enough to study it. It would be impractical to conduct a study of AEDs, and then there are also informed consent challenges. The victim is not responsive, and its moments count. So it's really difficult to do research into defibrillators, and so right now it's very difficult to study this, and it's not a problem I have all the solutions to. It's something I'm very interested in talking about. How do you handle the situation when you need to get informed consent for experimental therapy when the patient is unconscious and their loved ones and whatever are not likely around or can really understand in the short time that you need to go ahead and try to innovate. So it's a real challenge that's not going to be solved by getting the government out of the picture. They struggle with it too. But I'm glad we were able to study the waveform that's in our defibrillator. It would just be nice to be able to innovate further in the future. So when a randomized controlled trial for these various reasons aren't possible, observational studies are generally used. And what happens is that the treatment is not allocated to subjects by researcher, but chosen by individuals. So they decide if they want to have the treatment or not. And then, so the limitations of these is bias and confounding, because you don't have the randomization that solves for the confounding, and you don't have the control group. It's just people, you're just looking people that are taking the product. But one of the things I didn't put on here, but one of the things with observational studies that can be helpful is if you can see that they predefined what they expect to see in the population that took it. So when a researcher predefines the outcome and the hypothesis that they expect to see, then that really helps minimize some of these things, but not completely. There are different types of observational studies. A cohort study is where researchers select a population or a cohort, and they assess their level of exposure and then follow them over a long period of time and to see if they develop the outcome. There are others where it's a case control, where they select a group of people with an outcome and a group without, sometimes with a historical control, and then compare the levels of previous exposure in both groups. If you're using a historical control, a good question to ask is what was the standard of care at the time that historical control population was exposed to the product before, and because it can change over time quite a lot. Practice of medicine and all kinds of things can change. And or if it's in another country, then the better that you control the better that you match your controls, the better off you can be. Ecological observational studies are where researchers select populations, not individuals. My colleague, Mariko Geiger, helped me put these studies together, and she's an epidemiologist, and I had never heard of this before, but she knows all kinds of interesting things. So an example of this is the effect of bicycle helmet laws on the rate of head injury. And these studies can be pretty severely flawed because they're looking at groups of people, and there's a lot of confounding stuff that goes on with it, and people want to see that bike helmets help, and so it has all kinds of biases too. So now moving on to interpretation. So when you're looking at an advertisement or you're looking at a study, or if you're like me and you see an advertisement after a doctor recommends something and you look it up on Google and you look for scientific papers, you'll see different things reported in those papers. And statistical testing, I took a class in statistics in college, and I just it was really difficult to understand how to apply it. But after working in the business for so long, I've gotten to know a few things working with my statisticians that I work with. So testing statistically is based on the possibility that sometimes associations are simply due to chance. And so if a statistically significant relationship is found, it's unlikely that the relationship is by chance, but it is still possible. There's always a chance that you saw a good result that was just based on the fact that there weren't quite enough people to be sure that that was right. When a study is looking at many different comparisons, the possibility of chance error is multiplied. So when you see a study that reports decrease in deaths, decrease in myocardial infarctions, decrease in lots of different things that they've looked at in the same population, the chances that they're all good is the chance, if they report all good results, the chances that there's an error in at least one of them is multiplied. When a study is looking, let's see here, replication is really critical to scientific inquiry. The more times the result has been replicated in separate studies by separate researchers, the more you can trust it. And an example, one of the examples I researched before this talk was medical marijuana, and I was very surprised to see how few studies there are on it. Yeah, I don't know. I sort of expected to see more just based on all the policy talks that go on and all the other stuff, but problems, Christy. Yeah, she's asking, can they study medical marijuana? What I heard was that when I saw when I researched this, is that there is one, I guess a lab, I don't know, one site in the U.S. where you can requisition marijuana for studies, and the studies I saw, I only saw 2 studies, and they were in very narrow populations and very limited numbers of subjects, a single site, I think, where they tested marijuana cigarettes versus non-marijuana cigarettes, and they called it blinded, and I find this impossible to believe. So I'm very suspicious of those studies, but I would love to see more. And so, I wanted to see more.
There's some stuff out there, cannabinols being extracted, purified, and presented as a
Okay, so maybe.
Yeah. And there's plenty of information on that.
Okay, so maybe that's what they did, but I looked for that in the paper and I didn't see it, so I was suspicious, but it would have been better for them to explain that you could still, that it really was blinded. But anyway, replication is really important. I would love to see more medical marijuana studies replicated, and maybe not, just in the US it's really locked down, but I've heard other countries like the Netherlands. Oh yeah, there you go. Yeah, do more studies. That's really helpful. And sometimes when you look at medical product studies, you see something called a p-value, and if it's less than 5%, which is reported as p less than 0.05, the chance error, it's considered acceptable, statistically significant, but this is somewhat arbitrary, so I want people to know. They're saying there's a 5% chance this result might be wrong. And so just keep that in mind when you see things like that, or sometimes you see p equals 0.0001, quite a few zeros before the 1. You can have a lot of result is probably right. But if it's like 0.049, you're kind of, they usually would say less than 0.5 in that case. But that's sort of a ballpark. And it's not like it's written into our regulation, but FDA never approves something, as far as I've seen, that's more than 0.05.
Right, but can I add to that though?
Sure. Yeah, Jody.
Those might be reported that way, but that doesn't make up for a badly designed study.
Very good point, Jody. Jody's saying that even if you have a p equals less than 0.05, that doesn't necessarily mean the result is something you can count on. Because that also has to do with statistical significance doesn't always translate to clinical significance. That's my other point on here, that just because mathematically the result turned out that way, because maybe the way they designed it or whatever to do that. Yeah, confounding and bias. Yes, that happens a lot actually. And so that's a really good point to think about what that outcome, does that outcome really matter to you? If you're able to show a statistically significant result in terms of, mathematically, in terms of reducing blood pressure from, systolic blood pressure from like 150 to 149, so what? It's, that's not very much. It doesn't really matter. And another example, so an example of sometimes the way you see this, patients who receive product A had a significant reduction in cardiac death and myocardial infarction compared to patients who received product B. And then you'll see it in parentheses, p equals 0.003. I took this off of a study I looked at. But a question on that one I would ask is, did they adjust for multiplicity because they're reporting both death and myocardial infarction? So I would ask questions like that. A lot of the time they don't. I would even say most of the time they don't. So be aware that even with a significant result like that, if they report multiple things, it might be less than that, really. And then my other provocative question is, would you believe a conclusion that was p equals 0.051? This wouldn't get approved by the FDA, but it's probably okay, And so I just want to get people thinking that way.
Well, the other...
Oh, go ahead.
If I might add, the other thing maybe that you're going to touch on is, what's the condition?
Yeah, what's the
if
condition?
If I'm terminal cancer, I'm going to try pretty good. If it's controlled diabetes, maybe not so much.
Yeah, exactly. That's a really good point. Yeah, it's depending on what the condition is, you can really you can have a different level that you'll accept, a level of scientific rigor, and like what I was talking about with defibrillators. Thank goodness we have them, but it's really hard to study them. And thank you, and I will use it if you do. So and you do.
Kind of like organ donators, though, right? It's like your price. Yeah. So you could have that too.
Yeah, there are some people with do not resuscitate bans. I've even heard of tattoos. All kinds of stuff, and I absolutely respect that. But yeah, it's difficult. Yeah, Sharon.
There are two more caveats about studies. In a recent issue of Scientific American Mind has an article about professional subjects. And the researchers are so eager to get subjects, they're not as fussy as they should be about who gets to be a subject.
That's a really good point too. Yeah, Sharon's saying that some researchers are so eager to get study subjects because they get not only money for each patient that they include in a study from the manufacturer of whatever product is under investigation, but they also, and probably an even more important motivator to think about, is that they get to be published, and that really helps them advance in their careers. And just be careful when you're working with investigators there, that can be a bias in selecting the patients for the group, and sometimes papers put it in the fine print, that some of the subjects didn't have all of the inclusion criteria, but we presented it, and sometimes they'll present the results without those patients, and sometimes they'll present them with the patients, and just be careful when you're looking at that. It's definitely an issue. So yes, question.
I think something else that's kind of hard to find, but equally important to look at when you look at bias is some of that lab whether it's being funded, by the actual drug company or by some other entity that looks like it's not at first related, but then come to find out that they're kind of holding hands.
Absolutely, and that's a really good segue into my next topic here is the comment here that it's really important to follow the money. It's always important to follow the money. If you're seeing something that seems too good to be true, or something that doesn't make sense to you, or the numbers just aren't adding up to you, or even if they are, just be cognizant of where people are getting the funding. The funding for virtually all medical product testing comes from the companies that make the products. And that's the only way you can get the research done. But, just be aware of that, they pay for healthcare also for the subjects. So like routine follow-ups and stuff. And so sometimes people can get free healthcare if they sign up for a study. And that's to Sharon's point earlier that you can get professional subjects that way also. So there's incentives for them that way. That's good. Oh, yeah, question?
I'm just curious, the correlation between the need for all these drugs and the production of food, and it's like what is being passed off as food, and like it spins back around as to why we need these drugs to cure these diseases that are being caused from things we're eating. And I don't know if you want to touch on that.
Yeah, I'm not. The question is about foods and comments on all these drugs that are being used to address issues that are caused by foods and things like that. I'm actually not super familiar with a lot of the food issues. I know a little bit about wheat allergies and things like that. I do see that because medicine has really changed over the last century even, and to where doctors are spending less and less time with patients, and if there is a drug that is purported to be treating something, that's what they go to first, because it's hard to get a patient to change their lifestyle. It's hard to get someone to quit smoking. It's hard all these things are hard, and they take time, and time that physicians don't have. And the other thing is, it's not all their fault. Sometimes they can get sued if they don't prescribe it. So, because that becomes standard of care, because it's so easy to write a prescription, and it's so hard to do these other things, that then it becomes standard of care, and then they can get sued if they don't follow standard of care. So it's an issue for sure, but it's something that the more people that are aware of that being an issue, the better empowered we can be to help make good decisions and work on things and help each other work on things, rather than always relying on the prescription pad of the doctor. And some of them are great, but I had a doctor that was fantastic and always took time to do the harder things, and he got out of it because he didn't to be in practice anymore. And I was sad about that. And he was an OBGYN, and the insurance for those guys is crazy. So he couldn't make money with the time he wanted to spend with patients. So that was sad. Anyway, I'm going to go on, just have one more topic to cover here. One of the things that FDA never makes people report in their labeling or anywhere else is responder rate. And this is really important. And it's also important to those of us who care about being individuals versus collectivists, and especially when it comes to cancer medication, chemotherapy. So there is a organization called the ASCO that looks at different chemotherapy drugs, and it's really all over the place. There is no one chemotherapy. There are different combinations of drugs for different cancers and have been studied in various different cancers. And this is an example of something that the ASCO came up with as a tool for doctors to talk to patients with, that I really like to see, but I never see it in drug product labeling or anything like that. This is what you're looking at here is, sorry, it's kind of hard to see with the blue background. I didn't think about that, but what you see here are the patients that would die anyway with or without the drug. The red is the patients that survive anyway with or without the drug with no effect. And this 13 over here is the patients that benefited from the drug. And the ACO was recommending, and this one is worse, it has only 10% benefiting from the drug. These are chemotherapy drugs. These are nasty drugs. And if you knew that only 10% of people benefit from it, would you really want to do it? I think that's up to each person to decide. You know, I think some people would say, yes, I'm willing to go for it. They live 2 months longer. You know, this 10% of people live 2 months longer with this, taking this nasty drug. I'm going to go for it and try to do it and try to make it. But like, and especially when it's chemotherapy, if it's only 2 months and only 10%, my goodness, I think I would probably decide not to do it. But this, and that's exactly what was going on in this study. And this is something I never see. I never see in labeling. I'm glad the ASCO is recommending it for tools for communication with patients, but I just don't see it very often. And so one of the things, this was actually, this quote, I'm going to read it to you. This quote came from a recommendation saying, oh, chemotherapy drugs work after all. But it's really telling that even in this article that was recommended and saying how it's proven effective, they even say what the issues are with it that I have with it. While it's true that chemotherapy decreases a woman's risk of dying from her breast cancer, the vast majority of women do not individually benefit from chemotherapy. In order to save that 1/3, in this case it was 1/3, not a 10th, in order to save that 1/3, we have to treat most women who segregate into 3 groups. Those who would have done well without chemotherapy, who are treated unnecessarily. Those who would do poorly regardless of chemotherapy, who are also treated unnecessarily. And those for whom chemotherapy is the difference between life and death. And so these standards of care and public policies all recommend that everyone get it. But you know, I don't think everyone would want it if they really knew all the facts. And the other thing to consider is this conflict of interest, follow the money. Because chemotherapy has to be given over a long period of time, a lot of cancer oncologists set up businesses that would administer the drug. So instead of just writing a prescription, which doesn't have as much conflict of interest, they would buy the drugs in bulk from the drug companies. And some of them were allowed to have more profit than others by the government. So, just think about the bias in that and the conflict of interest that can crop up from that. You know, these doctors that are recommending a certain drug to a patient, nasty drug to a patient, and there were studies that showed that there were differences in, I can't remember the results and I didn't write it down on here, but there are some that there were more prescribed that had the better profit allowances than the others, and that's just, you know, unfortunate. And I think I would like to believe that most doctors wouldn't knowingly do this, but definitely follow the money always. It's really important to know and think about who benefits from things and do some research online before you have to do something interventional like that. Yeah, Stephanie?
I think a lot of people, I mean, it's possible to do this subconsciously, have a bias and not even know it.
Oh, for sure.
Like you said, they may not knowingly do this, but actually there's been other studies that show when doctors have pens and merchandise that has logos on it, they're more likely to prescribe the one that has the logo.
Yes.
From that company.
Yes.
So some of them even will like black out those logos and take them off the bags and just use the swag, but not the advertising.
Yeah, I've seen big changes in the industry since I've been working in it for 20 years, and you know there've been a lot of voluntary agreements among industry associations to get rid of a lot of the free giveaways that Stephanie's saying can cause physicians to have biases. But of course, as soon as the industry decides not to do it anymore, then the government makes it a requirement. That's kind of the way it works. and then they claim that it was all their idea, you know, and that's generally what happens. And so there are biases created from the giveaways and things like that, but I don't want to, you know, I want to emphasize again that probably the publication bias is even greater. If these investigators and physicians know that they're going to be able to be a principal investigator and be named on the paper that results from the study, that is very motivating to a lot of them. And so be cognizant of that too. Some of them are just really interested in advancing their careers, getting more patients, expanding their business, because that's how they make profit too, you know, a lot of them. And that comes a lot from publishing. And that's what they know. The most of the studies that are going on are funded by healthcare product companies. And so they would obviously have a bias toward those ones that pick them as the investigator most often. So to conclude, I just want to reprise what I said at the beginning. When you're evaluating a healthcare product for yourself or a loved one, ask, is the study design appropriate? You know, if it's a observational study, did it have to be? Why didn't they do a randomized controlled trial? A lot of observational studies are in populations that could well have been a randomized controlled study. Some of them aren't, though, so think about that. You know, are they studying the right outcomes is another part of design, you know, what we talked about earlier. Is it well conducted? You know, were they meticulous in their collection, or did they, were they missing a whole bunch of people at the 1 year time point and just report on the ones they had? You know, like that. Did they, if it's something like a coronary stent, were they really looking for the right things down the road, really making the right measurements that you can see what's going on? Were subjects informed of risks ahead of time? That's just something that's, you know, rock bottom critical. Informed consent, you know, there was a big flap about a decade ago with some cancer studies that did not adequately inform patients of risks before they did those interventions, and that's just unacceptable. How strong are the results? You know, assuming the results are that you care about, you know, do they report statistical significance, and to what extent? How generalizable are the results? Is the you really can't believe that something in patients with a certain type of severe treatment-resistant high blood pressure, for example, would that be applicable to someone with blood pressure of 140 over 81 or something like that? You know, how much do you believe that the study population is applicable? And then what percentage of patients benefit from it, like those chemotherapy drugs? You know, what? Really think critically about that, because that should factor into any decision in whether you recommend it to someone you care about. So, yeah, I think that's it. Yep. Yeah, Christy.
You're getting clapped. I generally try to go the healthy route first. Find a natural, whatever. I don't like taking drugs.
Yeah, me too.
But in the case that I do, I'm probably not going to go through all of this. Have you thought of like creating a third-party rating system? Or
absolutely.
Because I would, you know, that would be a place to go.
I would love to do that with free aid, and I know so much about what's available. You know, with FDA publishes a lot of stuff, and a lot of it is good information, but some of it is missing, and some of it is biased. You know, because once they've approved something, they want to defend it no matter what, because they don't want to ever admit a mistake. Exactly. And so, so there are some issues like that. And free aid never accepts government money. We never will. All of our funding has been very grassroots, and we really appreciate the generous support of our donors. But it's a project that I've listed that I would like to do with free aid in the future. I'm busy with all things.
I was just thinking, yeah, to everybody, and they can call you when they need the research.
Hey, actually, you know, I would be really happy. She's saying, you know, you definitely contact us via freeaid.com. We have a contact us forum on there. Maybe we do have our phone number. We do have a phone number that forwards to us as well. It mostly goes to voicemail, but that's another way to contact us. If you have a specific question and want my advice, I'd be happy to help. And Mariko Geiger, my colleague who works at Harvard, and the epidemiologist who helped me with this talk, couldn't be here, but she and I would be happy to help with questions that come in for us. Yeah, Sharon?
You want to hear another creepy caveat?
What's that?
My partner Art used to work for one of the companies that oversees drug testing, and he quit. He said, you know, I never want to take a prescription drug again after he saw the hanky-panky that went on.
Oh, for sure.
And I don't know how we learn about that. That's a tough one, but just be aware that not all of these study results are on the up and up.
Yes, I totally agree. Sharon's saying that her partner stopped taking even prescription drugs just after seeing all the stuff that goes on after working with it, and I do too. I avoid drugs as much as possible, and even some foods as drugs. You know, like I avoid drugs as much as possible, whether they're legal or illegal. I don't care if they're legal or illegal. I don't make that distinction like some people do, and it's something I think critically about, no matter what it is. And yeah, I've seen too much too. and drugs have systemic effects on the whole body that you can't always predict and aren't always measured. So I'm a little bit more inclined to get a device if I need one than a drug, just because I can wrap my head around what happens with the device a little bit better, depending on the nature of the device. Some devices for the nervous system are kind of similar to drugs in the way you don't really know what's going to happen. So that's right. Yes?
The legal medicinal bar for blood pressure has gone down. It doesn't have anything to do with being able to push more drugs, like having higher blood pressure now?
Yeah, it could be. The question is because the threshold for prescribing medications based on blood pressure has gone down. So now it's 140/80 is considered the point at which it gets treated, although it can be lower, like 135/something. I can't remember. I think it's 135 for patients with diabetes also, with high blood pressure. But and she's asking if that could be the result of pushing from drug companies. Absolutely, absolutely it can. But look into those results. Look into not only, but this is a good example of a surrogate measure. Blood pressure isn't necessarily in and of itself bad. You know, what it does is that there's been an association between high blood pressure and cardiovascular events. And stroke and, you know, pretty severe cardiovascular events. So the question really to ask there is, have there been any studies really done that show that, you know, 140, a blood pressure of 140 really causes a lot of cardiovascular down the road? And there are very few, actually, as far as I know. There aren't as many as there were in the higher blood pressures. And people just get used to, it is a very good correlate, you know, having high blood pressure, but I just can't wait to push it. There are a lot of good ones, but when there are vested interests in writing a prescription, including publication as well as money, then that's what I'm for, and potentially get a second opinion from someone that's less conflicted. So, yeah.
How accessible or readable are these articles? My level of intimidation is that
Yeah.
I'm not really. I'm not even afraid of the statistical results, but it's just the medical lingo. They will be talking that my eyes will glaze.
Yeah. Jody's asking about how readable are the articles. Some of them are much better than others. I guess after just having a lot of experience reading a lot of them, I've gotten reasonably good at it, but some of them are written by people with English isn't their first language, and some of them are very heavy in the technical details and jargon, and they can be very difficult. I agree. It's better when companies can translate the results accurately, but you always have to be careful when they do that. I would like to give some examples in future talks of advertisements versus the studies, and really show people how they can get warped in trying to make it readable, and then the other companies do much better. Yes?
Perhaps the hugest thing in my lifetime is this whole TV advertising. Because I think, more than anything else, driven.
Yeah, TV advertisements. Yeah, it can be, but yeah, those TV ads are so weird. You know, they're on prime time. Yeah, they have all those side effects at the end, and yeah, those are. It's hard to believe they'd be effective for anyone. They don't work for me, but yeah, I guess they would be. Yeah, maybe. Yeah, I think you were.
Can it be generally safer to go with a natural alternative?
Not necessarily.
Yeah, exactly. I would say not necessarily. That's like, for instance, you know, medical marijuana is natural as they come, but there are very few studies, like I said. So, you know, follow the data, look at the data.
I can add to that.
Yes.
I happen to be a chemist. Some of these natural alternatives have not been forced to be tested for purity as much as
Sure.
things that you get. So you can
Or
get a lot of
effectiveness, for
crap.
that matter.
Yes.
You can be getting some, you know, pesticides from China ground into your ginseng.
Right, right. So they're not always as pure. And the other thing about them is that there aren't usually as much incentive for companies to test them. Like there isn't really, because it's, for instance, marijuana is easy to grow, and so it's not patentable. So who has the interest in studying it for effectiveness? And you know, thinking it through, it isn't that surprising that there aren't that many studies. You know, there really aren't incentives for people or organizations with deep pockets to study natural things that can't be patented. So this is another way, in my opinion, that intellectual property kind of hurts innovation and science. So anyway, yeah, you had a question?
Yeah, this is kind of related. But we hear about people who don't go to doctors and doctors. But I'm thinking that there's also a lot of people who perhaps go to doctors to apply.
Oh, I completely agree. Yeah, his comment is some people don't go to doctors enough and others go to them too much. It's well known that certain categories of people, I'll say, you know, avoid doctors more than others and are really underserved. Not only poor people, but for instance, Black people tend to, it's been studied, go to doctors less, and a lot of it is just mistrust. After some of the stuff that happened with Tuskegee experiments without consent and things like that, there are people that are very suspicious of medicine. And, but on the other hand, you're right, there are other people that, you know, either want attention or feel like they want to have someone care about them that maybe go more often than they need to. So, yeah.
Being aware of their health and everything is good, but it also seems to me that you can also slide over easily into a dark side where you become obsessive about it.
Yeah.
And want everything to be so perfect. And that you find yourself delivering yourself into the hands of doctors. Tell a doctor, if you insist on doctor, something's wrong with you. After a while, you might just find this guy, okay, I guess we can find something wrong.
Exactly, and that's when the prescription pad comes out, and there's a pressure on doctors to give patients what they want. Yeah, I think we need to wrap up, or do I have, or what's the scoop? Okay, maybe one more question then?
When you get on Medicare, the doctors can wait to just prescribe anything
Yep.
and everything, send you to another doctor and get tests, and it's nonstop. And they have to do it because it keeps the wheels greased.
Yes, yeah, yeah. And sometimes they're important to follow through on, and sometimes they're not, you know, so, but there are a lot of pressures, like we've been to get the prescription pad out, follow through on testing or whatever. But there are sometimes pressures for them not to do it, cost containment pressures that you also have to be careful about. So what are they not pushing on you? And sometimes referring to other physicians that you might need, they have an incentive not to do it sometimes too. So be careful both ways. Yeah, well, I just want people to know that you can be empowered. There's so much information available now, and we're here to help too, like Jody suggested, with specific questions until we get our, third-party database of information out there. Please, follow through and know that you can ask those questions.
Maybe you can start with just case studies, things you've researched, and just put them up on the free
I can?
site.
Yeah. Oh, yeah. That's a good idea.
Turn into a
Sure.
big database.
Yeah, that's a good idea, Jody. Yeah, suggesting that we put case studies up there. That would enable me, because I have a day job as well as doing various types of activism. So, maybe we'll do it a little at a time, baby steps. Yeah, that's a good idea. All right, well, thanks, everyone. Don't forget CPR workshop at 1 at the Garden Green. So, thanks. Thank you, Jody.